So, good evening. Welcome to this session on autism spectrum disorders. We have eminent speakers today. Dr. Shambhavi Seth, she is senior pediatrician in South Delhi and had been secretary of the neurodevelopmental chapter of IAP. And we have Dr. Praveen Suman, who will be speaking on the management afterwards. She is the senior pediatrician at Gangaram Hospital. And without wasting much time, we are live now on the YouTube also. The recordings will be available. So I request Dr. Shambhavi Seth, ma'am, to please start sharing the screen. And I request everyone to please keep your mics on mute. And please go to the first slide. Yes.
So good afternoon, Dr. Ajay. Thank you for this opportunity and organizing this webinar. So if you want to wait for a few minutes, or should we start now?
We'll start and we'll have the recording available, which we will share.
Right, sir. So good afternoon, everyone. I welcome you all to this webinar. Today, we are going to talk about autism. And one of the reasons I think this has become a hot topic, because as a pediatrician, a lot of us are seeing this autism or communication delays or deficits in our day-to-day practice. So the topic given to me is about the early diagnosis of autism. And to touch upon this, we also need to know why this surge of autism is happening, what has happened, what has changed in last 4 years, especially since the COVID pandemic in 2020. Lot of these complaints and these kind of cases have, the OPD footfalls have increased. So if we see, the prevalence of autism was almost 1 in 54 children in 2019. This is as per the CDC reported data. And now in April, latest data is like in April 2023, it is almost 1 in 36. So which is a huge jump in almost 4 years. We also have seen there is also so much of increase in the screen time by children, and almost 87% of children are on the screen by the age of 3, and 90% have started the use before the age of 1. And we all are aware how the children are eating these days. I've not, at least in my practice where I see children with communication deficits, the history of screen time is so universal. So leading to this, but are these all children who are coming to us, are they really autism, or is it something else? I think we need to mute there's some disturbance coming. So, so when we talk about autism, autism is a more definitive terminology which we are using to describe not only an impairment in social communication and interaction, but we also have another set of symptoms that are restrictive or repetitive patterns of behavior. Only when these two criteria are met, we call it as autism. So when we have a child who has developing, who we see like autism, or sometimes we put a diagnosis of virtual autism, I also see in many prescriptions, what are we dealing with? What is the prognosis of the child? And rather, how do we advise the family to manage that child? This is going to be the essence of our presentation today. To understand what is autism, we have to first understand these terminologies, which is, as you can see, communication, which is a big blue circle, followed by language, and then followed by speech. So why communication is a bigger circle? Because communication is a very basic exchange of information which is happening between two people, which is the social aspect of it, and it has to be meaningful. So if I look at you and you look at me and we smile, so there is still an exchange of information which may look like a pleasant greeting, and we have done a meaningful exchange without speaking anything. So this is communication where there is a meaningful exchange of information between two people. Many times the parent would come to us and say, "Ki child is learning a lot from screen. They have picked up new words, new vocabulary," but it is only one way. Like, right, the child hears or listens at the screen and sees something and starts speaking those words, maybe a rhyme, ABCD, or wheels on the bus, whatever they are picking up. But that is not communication. They have just picked up from the screen as a by a repetition or rote learned language. So communication is essentially between two people, which we don't forget, and it is a meaningful communication or a exchange of information, which can be either non-verbal without any use of any language, or it can be verbal. If when we talk about language, it is a more defined code, like which means, like if I say apple, apple is a fruit, it is red in color, it is a word of English language. I cannot say apple purple, or I cannot call apple banana. It has a defined code and thereby a meaning attached to it, which is the language. So we have multiple languages. We can have all the languages can be spoken, it can be a read, it can be a sign language, right? So this all has a certain meaning to those words. The way the meaning is expressed, that cannot change. It has to follow certain set of rules. So again, language can be receptive or expressive. If I am saying, giving, saying a little boy, "Ki say hello to auntie," so it is a receptive language and child follows my command. But if the child says, "I want water," then becomes expressive language. And when we talk about speech, it is the spoken aspect of language, which we are saying as speech, which is basically to do with articulation and the expression of that language. So once we understand there is a difference between communication, language, and speech, we also have to look for these phenomena, these things which we see in our children. Something which is very important to be looked into in children who are younger, I mean less than 2 years of age, whether what kind of a non-verbal communication without any speech they are making. So we look at a child's eye contact, we look at facial expressions, what kind of expressions the child is, it happy to see the parent or is scared to see the doctor, joint attention, pointing, symbolic gestures like, waving a bye. If they want water, they can say this. They want food, they can do this. Social gestures again, like bye, flying kiss. So we'll have to look for all these non-verbal communication sitting in our OPD. And it is interesting that even a child who has not spoken a single word by 18 months should have a good non-verbal communication, because all these start coming in early years. So this is mutual gaze, where a child is looking at the mother, they are sharing attention with each other. Joint attention, it is very, I mean, it is important to understand, because this is one of the major things which is lacking in children with autism, is a joint attention. And what do you mean by joint attention? Joint attention is when we are jointly attending to a task or an activity. So like if you see in the first picture, the mother and child both are looking at something, and they are also going to exchange the glances with each other. So, like if a child who is at 9 months of age and the mother is showing the rattle to the child is happily looking at the rattle, but now has also understood it is the mother who is showing the rattle. So, will also look at the mother. So, when they are jointly attending an activity or a third activity or a near activity or a far activity together, that becomes the joint attention, which we will see when it starts to emerge. Pointing, which is a mature pointing, is when a child is able to use an index finger to indicate what he or she needs or what he or she is happy to see. But many times in our OPT, if you ask the parent कि pointing करता है, the parent would say हाँ अपनी बात को point करके समझाता है. And if you go a little step in detail, if you ask them कि कैसे point करेगा, वो many times they would be saying कि वो मेरा हाथ खींच के लेके जाता है, अपनी मम्मी का साड़ी खींच के लेके जाता है, which is again you have to understand it is a immature pointing. That is not the mature finger pointing which should have been developed in that child. So a little bit more science about communication. We have so frequently talked about the red flags of language, red flags of motor delay, but let us just talk about how this communication has started and how it has evolved in a very, very young baby. And it is an interplay of not just social or a communication, it is an interplay between social, emotional, cognitive, and language domains of development. So if we see the stages of social emotional development, right at the time of birth, child doesn't know I'm born to so and so set of parents. They are my grandparents, they are my parents. The child is not aware. So how the child who is just a newborn perceives the world? The child starts to perceive the world through its senses. And by senses, I mean the sense of hearing. They may hear the mother's heartbeat in the womb. They may start looking at the face of the mother they see so frequently when they are born. They may smell the breast milk. They may understand the touch of the parent and taste. So, all this is the sensory perception the child starts to get. And once these sensory perceptions they develop, they may also start to have an emotion. So if they drink breast milk, they are happy. If they have a little painful touch, they may cry. So basic emotions like happiness, anger, sadness also start to emerge in newborn stage. And gradually, once they regulate and they start sharing attention, by 2 months of age, a child will start to develop a social smile, which is the first social emotional development milestone we see. Now, coming to the second stage, which is,
वो है ना उससे आगे
I think you need to mute the participants, please, the host.
हाँ
So, coming to the second stage, which is from 2 to 5 months, is where the child starts to develop social preferences. They look at the mother and they start recognizing it's a familiar face. I prefer looking at this face, which is smiling, holding me. They start to express
पहले वाले
emotion.
टर्न में जाएगा या अगले वाले
They may smile more. They may start to read
पहला
facial.
लेफ्ट
They may start to read the facial expressions and
तो याद
start.
नहीं आ रहा कहाँ पे मेरा ख्याल है सेकंड लेफ्ट लेना है
I think please mute the participants. It is very, I think, disturbing for everyone.
हाँ
Dr. Ajay, are you there?
I'm muted, everyone. And just please unmute yourself.
Yes.
Please unmute yourself.
Thank you so much, sir. So, at this stage, the child starts to develop social preferences. They may express emotions more regularly, looking at the parent, and they may start reading their expressions, recognize the voice patterns, and the engagement starts getting prolonged, where the actual engagement starts to build up. And coming to the next stage, which is between 6 to 9 months, the chaining, which is like to and fro exchange, become more prolonged. And this is like a chain which starts happening between the caregiver and the child. And gradually, by the 9 month of age, the child starts to get the joint attention, which we just spoke about, how the child understands. It is also the first stage of cognition, where the child understands this mother is giving me the rattle and I'm happy to see the rattle. So I also look at the mother and I'm happy to see the mother or the caregiver. So it's a joint attention, which is the first major milestone which is generally lacking in children with autism. So they may, what happens in joint attention, like child would not look at the mother. So if the mother gives the child a toy or a block, child is very happy to look at the block. They may start looking at the block, but they will definitely ignore the caregiver if you closely observe. Now, coming to the stage 4, which is between 9 to 18 months of age, the child has become more smarter. The cognitive development is happening faster. They now understand that if I do this gesture to my mother or my caregiver, she gives me that water. Or if I do that gesture, the mother opens the door for me. So they start using the gestures for solving their day-to-day problem, which is the problem-solving skills which start emerging. Proto-imperative pointing, when they do a gesture to indicate what they need. Proto-declarative pointing, when they are happy to see something and want to share the joy with the caregiver, they do this pointing. So this is how the prediction of social emotional behavioral patterns start to emerge from 0 to 18 months. So because it is not just one stage of development, all this is happening in continuation. And if this continuity is broken, so the child who has not spoken any word till 18 months but has lot of meaningful communication and social emotional understanding being developed from birth to 18 months, and if this continuity gets broken, maybe because of exposure of screen or any other environmental factor, the parent is not there available for the child, there are too many toys the child is getting but the child is not getting the affection and the presence of the caregiver, this process is disrupted. And that is when we start seeing the atypical signs where the child is not communicating, not connecting with the caregiver. So a little bit of screen time I want to highlight in my presentation, because a lot of times we start to correlate autism only because of the presence of screen time. So let us see how it impacts autism. What the literature says is screen time leads to early exposure to screen can cause neurochemical and anatomical brain changes. It can reduce the melatonin concentration, disturb the sleep rhythm, neurotransmitter deficiency like dopamine, acetylcholine, 5-hydroxytryptamine are also observed. Then the electrical and light stimulation has a direct effect on AMPA receptor, and these are the associated neurotransmitters which are also seen in children with autism like symptoms. So there could be a correlation with at a molecular level where the screen lighting is also affected these biochemical changes. Then there are numerous studies in last 3-4 years which have emerged, which are showing the association of early life social and digital media exposed experiences with development of autism spectrum disorder like symptoms. There's been this study, a huge big study in Journal of American Medical Association JAMA in 2022, where they have seen association between screen time exposure in children at 1 year of age and autism development at 3 years of age. And they had almost 84,000 mother child dyads, where they saw the boys with the longer screen time at 1 year was significantly associated with autism at 3 years of age, whereas in girls this association was not seen. But if the screen time is longer in 3 years of age, the association with autism was also not seen. So the screen time at a younger age, like children who are 1 year, less than 18 months, definitely, like we just studied about the different social emotional developments which gets impaired, the chances of developing autism or autism like symptoms are higher. So where we are now, do we say autism can be because of screen time? So we have to understand autism is a multifactorial origin. It doesn't have one origin, one risk factor. They could be genetic, they could be environment, and they also could be environmental factors. The environmental risk factors are there, but a particular child may have genetic susceptibility to that disorder. So every child who's on screen time is not developing autism, right? But why certain children are developing? So we also have to think about the genetic susceptibility in that population. And screen time, but definitely screen time or lack of social emotional stimulation, because screen time is also coming at a cost of absence of caregiver, right? Because the child is so much on the screen, child is not getting that social emotional stimulation from the caregiver. There the expression of autism, especially in younger children, is seen more. So screen time may lead to manifestation of autism like symptoms and more, but currently we cannot say it is the causative factor, but definitely it is associative with the risk of autism, and we have to see the underlying other causes also. So right now, this is where we are with respect to the screen time as per what I could understand and gather from different researchers. Now, coming to the diagnosis of autism, we know there is no diagnostic test, so to say, for autism, because it's a clinical diagnosis. There is no MRI we can do, there is no blood test we can do to prove autism. So what clinical criteria we follow is which is given by DSM-5 currently, which we follow. A lot of our tools are based on that criteria. So there is basically two main criteria about social communication and interaction and the repetitive behavior patterns. All three should be present as per DSM-5 in the symptom A category, and out of symptom B category, 2 out of 4 must be present. They should be present in early developmental period, and symptoms should be clinically significant to be causing impairment in social, occupational, or other important areas of current functioning. And these disturbances are not explained by intellectual developmental disorders or any other developmental problems. Now, coming to early diagnosis as a pediatrician, what do we need to understand? There are two things which we can do in our clinical practices, practicing as a general pediatrician, is a surveillance and a screening. Surveillance is what we generally see the child at well baby visits or maybe with mild cold and cough. We just ask about certain things what do we observe and what do we ask in the ROPD is about these early signs. By 6 months, are there any joyful or engaging expressions? Is there eye contact? What kind of eye contact? Limited eye contact, impaired eye contact? By 9 months, is the child making back and forth sharing of sounds, smiles? Has the joint attention developed or not developed? By 12 months, is the child babbling or very limited babbling? Again, the child has it started to point or showing or waving gestures like bye bye. Response to name has come or not come. By 18 months at least, the child should be speaking few words. Have they emerged? Meaningful words. By 24 months, the child should be making 2-word phrases like pani de de, bahar chalo. So is the child using that or just repeating what is being seen in the environment? So these are the early signs which we can observe and ask during the surveillance, which we can do at any particular time when the child is in front of us for whatever reason. The other thing which we can do is a user screening tool, which is a documented way of screening the child. And one of the most commonly used tool is the modified checklist for autism in toddlers, which is MCHAT, and it is also a freely available instrument, but it will detect the risk for autism. And as a pediatrician, we should not use it to diagnose autism, because if we say MCHAT is positive and the child has autism, it can really put off the family, because they are not looking for a diagnosis at that point in time, but they want to understand what that we are dealing with, right? So we have to make it more like what the MCHAT also says. I would just first go through what the MCHAT looks like. It is a 20-item questionnaire. The items are very simple. They have to, even there is a little bit of explanation with each point, and they just have to be marked as yes or no. And if we know it is a 20-item checklist, for all the items, the typical response is yes, except item 2, 5, and 12, where no is the typical response. And at the end, we score how many typical responses are there or how many atypical responses are there. Sometimes the parents are confused. If you ask them ki is it the child responding to the name, they say kabhi kabhi karta hai, kabhi kabhi nahi karta hai. So maybe we have to use our discretion also, what we are observing that time, and sometimes we just ask them more than 50% time कर रहा है. अगर आपने 10 बार नाम बुलाया, वो 2-3 बार ही सुन रहा है या कम से कम 7-8 बार सुन लेगा. So if the child is just listening maybe 2 times, they say, then obviously the response will be marked as no. But if the child is doing majority of the time, then it is yes. So based on the MCHAT, we have a risk profile of 0 to 2 is the low risk, 3 to 7 is the moderate, and more than 8 or 8 is the high risk. So low risk, we understand the child is not really at any risk for autism, so we can just we don't need to act anything intervention point of view. But if it is a moderate risk, we need to start some early stimulation or intervention, which we are also going to discuss in the next section, and closely follow up that child. But if the child has a high risk or a more than 8 score, then we definitely don't wait and refer the child for further evaluation, whether we are doing it ourselves or referring to a developmental pediatrician, whatever seems more possible for practical for us. But we also understand that MCHAT is a screening tool. So even if the child has high risk, it could just be a global delay or a developmental delay, because 100% of high risk group had delays or concerns which justified immediate referral. 54% children classified at risk on basis of MCHAT were diagnosed with autism. So maybe not everyone would fit into autism, but the child something needs to be done. So the message is, we don't have to have a diagnostic proven autism. If we see there are concerns and the child is falling into either moderate or a high or severe risk, we need to take action. And MCHAT can be done for each and every child. It can be done from 16 to 30 months of age. So 18 months, which is a 1.5 booster time, is a very good time, or also 2 years of age. And it is it is available in multiple languages. We can also train our clinical staff, paraclinical staff to do it. And like I mentioned, sometimes the parent is not sure, then we may help the parent in answering that particular item. So we, as a pediatrician, we can keep the printouts ready. We can also give the parent or clinical staff to fill the form in the waiting area while they are waiting for their turn, and put the phone number on the form if you want to get back to the family for after scoring. And quickly, if we want to see, we have to first see 2, 5, 12. Typical responses, no. So if we just count typical and atypical responses, and based on that, we can quickly score. So just to, for the ease of doing, if we just look at 2, 5, 12 and it is scored as yes, that means it is a atypical response there. And then we count the rest of the no's and count the total number of responses and profile the risk. The other thing which many times, like 16 months onwards, we can do MCHAT, but many times we do have concerns in children who are younger than 16 months of age. And for that also, we can use this tool, which is the Communication and Symbolic Behavior Scale, CSBSDP it is called. It is valid from 6 months to 24 months of age. It is also a very simple one-page tool which can be completed by a caregiver, which takes 5 to 10 minutes. It's a free resource. It is available on this particular website, which you can be easily downloadable if you want to use in your clinical practice. So it also has these predictors which measures emotion and use of eye gaze, use of communication, use of gestures, use of sounds, use of words, understanding of words, use of objects. So essentially what we all talked about in first 18 months of age, these are the things which would start emerging. And this is a very good checklist. If you want to use, you can easily use it in your clinical practice. So this is the CSBS DP checklist. It looks like this. And again, like I mentioned, it is a free resource available online. There are other tools to diagnose autism, but we are not going into the detail as of now. But just for information, we have an Indian tool called Trivandrum Autism Behavior Checklist, which is also can be used as a screening tool for community purpose. Then we have assessment tools. We have INDT AIMS modified. We have Indian Scale for Autism. We have CARS, which is the Childhood Autism Rating Scale. And then we have longer tools like ADOS and ADI, which take little more time. So coming to what now? What do we do if we see a child who has some concerns and we did a screening tool, we see the child has maybe a risk for autism? So like I mentioned, with the screening tool, we don't put a diagnosis, but we want to have a further detailed evaluation for that child. We do not wait for the assessment to start intervention. Some basic early stimulation tips, a pediatrician can very well do at that time only. They also need to follow up and monitor from time to time if the child has been referred to someone, that after 2-3 months, what has been the stage, what has been the improvement level in that child. Because once just referring to any professional is not enough. As a pediatrician, we all are aware about the developmental milestones at least. We can just see how the development is being on track, particularly related to the communication and social language part. And I think something which we should not do is immediately refer to a speech therapist or an occupational therapist, because many times, at least in my clinical practice, I've seen the child is getting referred and the child is not coming for evaluation. And maybe that one professional, I'm not saying all of them are like that, but maybe that one professional starts to work. There is no exchange, interdisciplinary exchange, and OT may just be doing OT for 2 years. The speech has not started, or speech may start doing speech therapy, the other interventions are not started. So it is a loss of the precious time and resource for the family. And also from the monetary point of view, we need to have a more comprehensive plan in our mind, and also to tell the family the same. Some of the early stimulation which we can offer is about play is the language of childhood. We understand. We do not jump onto child speaking or about the speech therapy. We have to first get the child getting engaged with us, ask them to reduce the screen time. There are screen time guidelines. Also, it doesn't mean the child has reduced or stopped the screen time. The child would start using more objects or object-oriented play. Many times I would see the child has been on off screen, but the child is playing with so many toys, right? There's a room filled with toys and the child is just with the toys. So that is also not going to enhance the engagement or looking at the caregiver. We have to be very actively involved, where we are making the child look at us, have a back and forth communication, which we talked about, the early milestones of social emotional. Involve them in routine activities, like, simply like mother is cooking, give the chapati to daddy, or put this glass on the table. Simple routine activities where the child is doing on a very regular basis can also be, child should be encouraged to be involved there. But I am sure Dr. Praveen is going to talk more about the intervention bit. This is it from my side. I would only say the role of parents cannot be emphasized again and again. Autism doesn't come with an instruction guide. It comes with a family who will never give up. And I think as a pediatrician, we have to understand the parent have to be made the center point for the program. And with our guidance, they can really emerge from that situation of distress.
Thank you, Dr. Shambhavi, for such a wonderful presentation. We have seen many children, say around 2 years or 3 years of age, coming. The child is not speaking much. Is speaking only 1 to 2 words. So I have seen many pediatricians just refer them to a speech therapist rather than getting a hearing test done and referring to and do a simple MCHAT screening also at that time. Because most of these babies, they are having some spectrum disorder only, autism spectrum. They have a communication disorder. We are also joined by Dr. Pankaj Garg, President-elect of Delhi. I request him to please say a few words.
I think the team is doing a good job. I'm impressed by the oratory skills of Dr. Shambhavi. She's an excellent speaker, and every time you speak to people like Dr. Shambhavi, Dr. Praveen, and we learn from you, and we definitely look forward to an autism-free society. And I'm sure you're doing a great job on that aspect. And as a pediatrician, I always feel that once you start getting into the depth of understanding of what is autism, you keep on diagnosing more and more. Otherwise, there was a time a few years back, maybe we were not diagnosing a single, and now every month we are diagnosing 2 or 3 babies. So definitely knowledge helps. Thank you so much.
Thank you, sir.
Thank you, Pankaj. Now, if we have any questions, please put them in the chat box. We'll take them later. And now I request Dr. Praveen Suman ma'am to please start sharing her screen. She is a senior pediatrician and developmental pediatrician at Gangaram Hospital.
Thank you, Dr. Ajay, for the introduction. Can you see my screen?
Yes, please go into full screen.
Achha. Is it okay?
Yes, that's great.
Okay.
Yeah. Thank you.
Good evening, everyone. Thank you, Dr. Shambhavi. It was very well presented, and I think she has set the stage. She has elaborated all the various points which are there in autistic children. And as developmental pediatrician, we always insist on early intervention. And Dr. Shambhavi has pointed out all the points by which we can pick them up early. So once we have started suspecting autism, then what is next? So as she has discussed, I will not go into the detail that we have to follow the DSM-5, which indicates that there is a restriction there is a deficit in social communication and social interaction, which has to be there in multiple contexts. There is deficit in social emotional reciprocity, non-verbal communication. So I would like to, I think, emphasize on this point. अभी तक हम सोचते थे बच्चा बोलता नहीं है तो ऑटिज्म है. No. बोलना तो बहुत दूर की बात है. Non-verbal communication is the most important clues, especially in early phases, as Dr. Shambhavi discussed. So by 16 months, you should have 16 non-verbal gestures. So if the child is not able to do that, that means the child is at a higher risk for developing autistic spectrum disorder. And later on, there is deficit in developing and maintaining understanding of relationship. There is restricted repetitive patterns, behavioral interest, which may manifest in the form of stereotypic movements, insistence on sameness, which may present as a lot of behavioral issues, highly restricted and fixated interest, and hyperreactivity to the sensory input, which has been discussed in detail. And these red flag signs has been discussed. I will not go into the details again. So I will just see few videos. If you want, you can see. As in this video, you can see a child is playing with the ring. But you can see how the child is playing with the ring. The child is just spinning the toy. So these are atypical movement, or we can say this is this is not the normal way of pattern. So whenever we talk about the play, कि बच्चा खेलता कैसे है, the generally as Dr. Shambhi also said कि वो बच्चा खेल रहा है, पर क्या खेल रहा है और कैसे, quality of play is equally important. तो वो खेल रहा है ideally with this ring. The child is supposed to do the stacking of the rings, whereas the child is just spinning the rings. And you can see the hand flapping and body tensing movements. Here in this slide also child was... Whenever you are calling the name of the child is not responding. Sorry. I think it got to the next slide. Okay. So then comes the intervention. What do we do when the intervention, when we talk about the intervention? So there is a whole list of intervention which has been there. And once you open the net, there are hundreds of things which has been given. Do this, gluten-free, casein-free, this, no sugar, this and that. So I'll just show you a chart which will show that what are the evidence proved recommendations which has to be done in these children. So there are interventions like, as you can see in the slide, chelation therapy, antimycotic therapy, immunotherapy, craniosacral therapy, and secretin. In between, these therapies do come in picture, but this is not supported by evidence. So these should not be recommended to the children. Then there are certain therapies which are weakly supported by evidence. For example, sensory integration, vitamins and dietetic supplements, gluten-free, casein-free diets. So they are recommended only in controlled and research studies. They should not be freely recommended to children with autism. आपने भी practice में, you must have also seen all these children are on gluten-free diet, casein-free diet, दूध बंद कर दिया, खाना बंद कर दिया, ये बंद कर दिया. Already these children are finicky about food. They have a lot of sensitivity towards certain textures. So once we reduce, when we stop the diets, then they can have a lot of dietary deficiencies also. So we have to be very careful before taking such steps. There is very common myth in the society about sugar. I think every second person, बच्चे को देखते हैं आप इसका मीठा बंद कर दो. I don't know where is this has come from, but there is no literature to support that. And we should not be, it is not that we have to give too much of meetha, but at the same time, giving no sugar is not the answer for these children. There are certain other things which we have to do, which I'll be discussing later in the lecture. Then there are social skill programs and cognitive behavior therapy, SSRI. These are also should be given under when there is a required. The most recommended therapy is the behavioral interventions. Behavioral interventions, maybe you must have heard of ABA. So ABA is not the only treatment. Now there has been changes in this. There are latest strategies which are called NDBIs. I'll be discussing. So all these children should be given behavioral interventions, and in case you have to give medication along with that because of hyperactivity or a lot of behavioral issues are coming, then risperidone is the drug of choice in these children. So you have to be as according to the FDA, you have to be aware of false and misleading claims of treating autism by chelation therapy, hyperbaric oxygen therapy, miracle solutions, detoxifying solutions, and stem cell, and all those things should not be given to these children. Then what should be done? These should not be done. Then what should be done? So as per the guidelines, IAP guidelines, the standard treatment for autism spectrum disorder is that first we have to make the provisional diagnosis, which will enable us to give the appropriate interventions to these children. No single therapy has proven to be effective in these children. So it is a multidisciplinary team. It is a combination of therapy which has to be given as per the need of the child. So in this, every child will have an individualized and tailor-made therapy as per the need of the child, where during the therapy, we have to focus on the core features of autism, which we have been discussing, that it is social communication and restricted repetitive behavior. Whereas most of the time you will see this therapies are based on the symptoms. Delayed speech and hyperactivity is not the core problem. These are the symptoms of a children. So if a child who is not speaking or has a delayed speech, and you say, by sending them to speech therapy, the child will start speaking, because there is no problem with the speaking per se. The problem is with the socialization and understanding of the language. Until unless you will not work on the language, the child, whatever the child is speaking may not be meaningful. So the therapy has to be based on the core features of autism, very important. And these therapies should be given home and community-based intervention. It is not that the child is going to the clinic, therapist is doing the therapy for half an hour in a closed room, and by doing that, we are satisfied that, my child is getting therapy. There is no point of getting such therapies until unless these skills are not generalized in the community. So very importantly, the parents has to be a part of the intervention program so that they can implement those programs at home also. And pharmacotherapy, like a lot of time children come who say that I've been taking treatment for autism for last few months, and child is on some of the medicines which we are aware of, omega-3 and this and that. So child is taking treatment for last 6 months, child is happy, but we as a pediatrician, we need to know that these are just supplements, these are not the mainstay of treatment. So pharmacotherapy has to be offered only for the specific target symptoms, and parents has to be told that it is mainly the behavioral intervention which will improve the outcome of the child, along with pharmacotherapy if required. And if the child has comorbidity, which may be in the form of intellectual disability, ADHD or anxiety, depression, so these therapies may need treatment. And very importantly, just sending the patient to the therapist, like once, like Dr. Shambhi has also taught you MChat, and now we see that a lot of pediatricians would do MChat, and after they think that they have done their duty by screening the child, and they have picked up the child that this child is at a higher risk for developing autism, and now he is not sitting, so send them to the occupational therapist. So according to them, they have done their duty. No, we are clearly saying just sending a patient to the one therapist is not the answer. We have to handhold the patient. We cannot just be letting the child with the therapist and whatever the therapist is doing, because after few years, after 3 years, 4 years, they come back and say, I've been doing this therapy and there has not been much improvement. And during this, we tend to lose our golden period of intervention. So it is the duty of the pediatrician to follow and to review the child, to see the progress of the child, whether the child is showing improvement or not. If not, then he has to take the help of a developmental pediatrician or the other specialist, whosoever is available in their area. Program should be reviewed and modified over time regularly. Any non-goal oriented and arbitrary, unending, repetitive symptom-based intervention should be avoided. Most of the time we'll see वो थेरेपी के लिए जा रहा है, कुछ तो थेरेपी हो रही है, but what therapy? What are the goals? So any therapy which a child is going has to be goal based. What are we looking at? Are we taking care of the core problems, social interaction? Are we looking into the skill training, understanding of language and cognitive development? And that goals has to be changed over a period of time. Just by doing pressure or giving a lot of pressure and giving sensory integration should not be the answer. A therapist is trained for one type of therapy, whereas in this child, you would need behavior therapy, you would need special education, you would need sensory integration, you would need speech therapy. So it is a doctor's duty to make the plans and follow those plans and see how is the progress of these children. So I'm sure all of you must be aware of ABA. Not really aware of, but you must have heard the name ABA because that's so much in fashion. ABA हो रहा है, ABA therapy होती है यहाँ पे. So ABA is a type of behavioral therapy which I will not go in too much of detail, which is socially significant, and there are behavioral changes is defined, measured, and you have to give therapies as per the underlying behavior. So for every behavior pattern, there is ABC. Like, for example, a child is crying or child is hitting the mother if he wants a toy. So there is a antecedent before that, which is known as what happened prior to the behavior. This is antecedent. And if your behavior is, if the consequence is favorable, then the chances that this behavior is likely to recur. For example, a child is hitting the mother that he wants a toy, and on hitting, you give the toy. The chances is that this behavior is going to recur because the consequence is favorable. So anytime you want to change the behavior, you have to either change the C or you have to change the BA. So this is how the behavior analysis works. So these are the basic principles. But now the ABA is not in too much of this use because there are a lot of challenges with the ABA. That is, whenever ABA is done, there is fixation with the reinforcement, and fading of prompts is difficult. And in ABA, you teach the skills. For example, you have to teach the child, de do, le lo, give, the, throw. So whatever you are teaching on the tabletop. And then you have to journalize those skills in the environment, which is a little, at times, become difficult. Now, to overcome that, the recent studies say that there is an NDBI, which is known as Naturalistic Developmental and Behavioral Intervention, which uses both behavioral approach to so that there is direct teaching and reinforcement are used, but there is a developmental approach so that you follow the developmental sequence, and we would like the child should learn in a natural environment. Instead of making him sit on the table and teaching the skill and then generalizing, you teach the skill in a natural environment. For example, child has a repetitive behavior of opening and closing the door. So whenever he's doing that and he has a motivation to do that, if you teach the open, close, that concept in that context only, the chances that child will learn faster. So this is how the child is being taught in a natural environment, and especially it is in this, what we follow is child's lead. Whatever the child is interested in, we follow those activities so that the motivation of the child is maintained, so that we can teach various skills as discussed by Dr. Shambhavi, the joint engagement and relationship building. All these skills are taught in a natural environment. So NDBI is at an intersection of behavioral and developmental approaches to early intervention. And emphasis is on developmentally based learning targets and foundation social learning skills. And delivery of the intervention has to be in the context of naturally occurring social activities, as I discussed. So important principles of NDBII is that it has to be started early in life. Because we are focusing on early intervention, early diagnosis has been done by the previous speaker. Now you start NDBI early in life once you have suspected the autistic spectrum disorder, and delivering treatment has to be throughout the child's day, not during the half an hour or 1 hour session when the child is going for the therapy. It has to be done by the parents at home throughout the day, and it has to be a treatment. There has to be goals should be very clear what we are teaching. Monitoring of treatment progress has to be done. Monitoring the fidelity of treatment implementation, involving caregivers in decision making. Very, very important. Whenever we are making NDBI, involve the caregivers. So it has to be family focused. So it has to be value based. It has to be qualitative. It has to be unique for the child. It has to be responsive parenting and adapted to the family needs. The basic principle in this that there are developmental principles, which is called zone of proximal development. In a child with autism, you cannot teach the child randomly, make him say, do this, ye kar do. It's not like that. You have to go sequentially. There are zone of proximal development. For example, the in the inner circle is where what a child can do unaided, and the third circle is child cannot do unaided. So we have to go step by step. We first, whatever child is doing, we have to go next step and then next step. So this is how we have to teach the child and make the goals, target skill level that is just beyond the child's current repertoire, facilitated by the connecting new behaviors to the child's current developmental level. Language has to be, language development is a part of the NDBI. Use natural language and lot of, display of gestures, emotional, raise your voice, emotional and facial and vocal expression show that child is motivated to connect with the other person. There is animated body language. It enhances the child's engagement with the therapist. There are a lot of reinforcements are used, which involve the delivery of natural consequences being preferred to the unrelated reward. Back and forth flow of interaction is not disrupted, and so there are various types of naturalistic developmental behavioral interventions are available with the name of pivotal response treatment, JASPER. I will not go into too much detail of all these. I'm just showing you the name so that at least you are familiar with such things. Reciprocal emotional training, early start Denver model, which is commonly used. I'll just show you one video. You have to get the attention of the child. For example, a child is sitting and is not interested in the child is not interested in looking at the speaker, but you have to so child has to be motivated, child has to be involved in the activity, then only we can teach the skills. And with early intervention, we can show a good improvement in these children. I'll just show you one slide where this is a child who came at the age of 2.5 years, was diagnosed as autism. So as you can see, the child is not able to speak, not indicating, not responding to the mother commands, and is showing body movements, non-body movements. And then he was put on therapy. The child is not interested, but we... So it is the child who is deciding what is to be done, and we are getting involved and teaching, and there is therapies are given. And after 2 years of therapies, so this child, so you can see, oh, I'm sorry. So after 2 years of therapy, child was declared the most amicable child of the school. He got the trophy. You can see he received the trophy also. So children can do very well if they get the early, appropriate and early intervention. And so the take-home message is early identification and treatment is the key to the successful therapy. And therapy should target the core deficit of ASD rather than symptoms. Speech, hyperactivity, behavior problems, these are not the core problem. These are just the symptoms. So therapy should not be based on symptoms. Focus on social communication and social interaction and restricted activities. Therapy that targets developmental principles in the naturalistic environment should be encouraged. Thank you so much. And I think if there are any
Please
questions,
stop sharing. Ma'am, please stop sharing.
just give me one.
Thank you, Dr. Praveen, for a wonderful presentation. Nowadays, many parents are visiting government centers. They get a MCP card, Mother Child Protection Card. If one looks carefully into that card, there are stages of development given in that. So if the child is not achieving those developmental stages according to the age, one can start the early intervention even before any problem is identified. And also many parents who are visiting at 6 weeks, 10 weeks, and while vaccination, they will start showing the mobile to the child. So getting them addicted to mobile at an early stage is leading to lots of problems. So there are a few questions I'll ask. Can point attention in ASD be present with parents and not with others?
So if
Dr. Shambhavi?
yes, sure, sir. So if the joint attention is there where the child is also regarding and looking at the parent, that means the child is not having autism. But we also have to see how much the child has been exposed. Like if the child has been at home all throughout and has no social exposure at all, so the child may not immediately show a joint attention to a stranger. So that also has to be kept in mind. But if the joint attention is present and it is like clearly it is a joint attention, then definitely the child should not have a high risk for autism. But I would just want to clarify here when we talk about joint attention, and most of the time if I ask the parent कि आप कुछ देते हैं तो कितना ये देखता है आपको, the parent would say बहुत अच्छे से देखता है. But if you ask them to do it, the child has been given something, the child is only looking at that object. The child is not even regarding to the parent for a second. The child may be only looking at the parent to get something when the child needs it, right? So that is not joint attention. So we need to be very clear about the interpretation, what we are seeing and how we are interpreting.
When the parent is showing something and child looks at that direction and at the parent, I think that will be considered more appropriate as
right,
joint attention.
Right, sir. Definitely.
So there's one more thing. Ma'am, if a child is having ASD with ADHD, then for overactivity, what to prescribe? I think we are not going into the medicines right now. Actually, medicines are tamoxifen or risperidone.
So the preferred...
These are specialized and should be left to the specialist only rather than prescribing in the OPD.
But preferred choice of drug ASD with the ADHD is risperidone. But sometimes, it depends how the child is responding. Sometimes child is not responding well. We have to go to the atomoxetine or we add the atomoxetine also. It varies from, but yes, risperidone is
this
generally
should be the field of the specialist only.
Yeah.
How to differentiate between functioning BS, high functioning ASD, and initially both types will be poor in social communication.
You want,
Yeah. So see, understand ki high functioning means a child would have a good cognition and child is able to function well in different environments. That's what we are saying high functioning. So there is no clear-cut diagnostic criteria ki this is the high functioning or this is the low functioning, though we do have CARS assessment tool, which is a different CARS assessment we can do for high functioning. But initially, both may be having, like you mentioned, low, poor social communication and engagement. But high functioning may have a good cognitive abilities and maybe functional well still. So a lot of times we see children who are in a school setting who have features of autism, but they are still doing fairly well academically. They are able to do their ADLs well. So that probably child would fall in a high functioning autism, but still has clear-cut features of autism as well.
Yeah.
Dr.
So I will just add. So autism, as we have discussed already, that is a problem of social communication. So IQ is a separate component. So intelligence, a child with autism can have a low IQ, can have a high IQ, or can have an average IQ. So depending on his intellectual capabilities, you divide into low functioning or high functioning. So that will help him in academic learning and thinking and all those. Definitely a child who has a higher intelligence level has a better prognosis than a child who has a lower IQ with autistic spectrum disorder. But both the need to understand, do not get confused between intelligence and social communication. These are two different things.
Thank you. Dr. Jaipal Kapoor, sir, has made a comment that MCP card has 3 colors, green, red, and orange. So each carries a different meaning. Red means he definitely needs a intervention by a specialist. And orange, you have to be watchful. And if the child is in the blue color, that means child is doing okay. So Dr. Swati Kalra has made a comment that is it not possible to label the child as autistic before 3 years of age? One of the patients residing in UK was told by the doctors that he can't be labeled so before 3 years of age.
So it is not. So we do have diagnostic assessments which we start doing at 2 years of age. In fact, now the AIMS modified INDT tool is from 1 year onwards also. And CARS scoring also we have 2 years onwards. So we can easily put a diagnosis. But sometimes if we are not sure, rather than going for a label and make a diagnosis only, it is better to start the intervention and then follow up the child closely. But many times in countries like UK and US, where all these interventions are based on a diagnosis only because the state is providing, they want a label and they may have their own criteria ki, once a child is at that level only, we are going to make a confirmed diagnosis and provide the intervention, because a lot of these are state or NHS covered in these countries and they need a separate criteria for the state to provide those interventions. Dr. Praveen may add something if I'm missing.
Yeah, true. Shambhi is correct on this part. And especially, these Western countries do not have enough professionals to provide the services. So once they will label a child, then they'll have to provide the service. So they do not label the child till 3 years or 6 years, because all of us are seeing these days a lot of patients from abroad. We are taking their online therapies because they are not getting any therapy. Parents are suspecting, parents are seeing that there are symptoms at 2 years, 2.5 years, but they are not getting any therapies and diagnosis. So they are taking online therapies from India. So they have their own logistics problem. Because of that, they are not labeling. Otherwise, there is no criteria, like you cannot label. If you have seen the recent criteria, DSM-5, there is no age limit which has been given. In DSM-4 there is to be a statement के 3 साल से पहले नहीं label कर सकते, but in DSM-5 there is no age criteria which says that you cannot label before this. You can suspect a child with autism in younger age, in infancy also. Labeling generally preferably after 2 years should be done.
So my only request to all my fellow pediatricians is do not label a child as ASD or autism unless the specialized assessment has been done. Even if I suspect any child to have autism or child is not doing so good on the MCHAT screening, I tell them there's some communication problem and it needs to be assessed by a specialist. I never mention the term autism. So because once they're labeled as autism at early stage without proper assessment, then the things go haywire. They are not ready to accept. And they will not even go for a proper assessment also. So that's all. I think most of the questions are done. And thank you very much once again.
There are a few more questions, Dr. Ajay, I think I can see.
In the meantime. We are not interested in labeling, and how to convince parents to seek attention for delayed speech. I think we need to tell them. We need to tell them. Speech therapist will not be able to help. We need a proper assessment. What do you?
Once you have done the MChat and you have told them that the child is at high risk for autistic spectrum disorder and the child may have developmental issues, so child needs a detailed evaluation depending on the level where he is falling. So only speech therapy should not be recommended. The child needs detailed evaluation. After that, in case child does not have autism, then probably speech therapy, you can go for speech therapy. But right diagnosis and right treatment is very important. Like any other illnesses, development में हम खाली बोल नहीं रहा, चल नहीं रहा पे क्यों ध्यान देते हैं? Why don't we diagnose, find out what is the etiology, what is the prognosis, and then give the treatment? And do not refer the child just for therapy. Again and again, we are emphasizing on this fact.
Dr. Raman has asked how to quickly evaluate a child with delayed speech in busy OPD practice. What I do is I tell the parents to call the child from behind the door. And if the child is playing something, child will never turn back towards them. And they will say, ki, "Bacha abhi busy hai." But you know in your heart that child is having a communication problem. Any other thing to say?
So, so I think what you rightly said, Dr. Ajay, is about the hearing bit. But again, the hearing, if there is any doubt, an objective assessment should be done. But apart from that, there are certain red flags of speech. If we just talk about the speech part, which is a child should be able to babble by the year 1 at the end of 1 year. By 18 months, the child should be having few meaningful words. By the age of 2 years, child should have a word vocabulary of at least 50 words or start joining 2-word phrases. So these are the early red flags. If the child is not having, whether you have observed or you have asked the patients on history, the child is not having these milestones at those particular ages, then the child needs definitely a further evaluation and diagnostic, the referrals for the appropriate referrals.
Methods to assess mental IQ in ASD children. I think these are very specialized things. Go to for IAP.
So there are tools available. There are tools available depending on the age of the child. Whenever we see the severity of illness, for example, you have screened a child who has you suspecting there is a MChat 10 aa gaya uska, so you refer the child for evaluation. Depending on the age of the child, if the child is less than 5 years, then DQ test is done. Various centers use different tests. Some people use Bailey scale, some use DASI for the developmental assessment. And for autism rating, we do different tests, autism rating scales, as Dr. Shambhi has listed all those tests, and sensory profile is also done. For older children, IQ test, normal Mullin's intelligence scale of Indian children is done for the IQ testing.
Dr. KVS Sai Prasad asked, do we need home visits also to understand child's problem?
Not a bad idea. I think it is an important aspect, because अगर वो therapy बस आके आधा घंटा यहाँ कर रहा है और घर पे कुछ नहीं हो रहा, then I think it is as useless. So looking at the home environment, how the parents are interacting, how is the home environment, all these things are important. But I think हम clinic में तो नहीं देख पा रहे. We are not able to do it in the clinic, and going to home. In Western, like when I was trained in US, and in US there used to be early intervention group who used to go to home for high risk babies and do the interventions. So there 30 years back also they used to do this kind of practice. But I think India still we are lacking in infrastructure, and if we can do it, I think nothing like it. It is very good.
I think parents should be involved to a great extent.
Yes, yes.
Because they have to do it regularly.
I don't know how much home visit would be practical, but at least in my practice, I would always ask for the videos of what the child is doing at home. And even if the parent is working with the child, how they are working at home. Because unless the parent has got the right methodology or they are doing the right way, I don't think it is going to benefit, because sometimes we may have explained something, but they may have understood something else. So we need to monitor it through the videos. I feel is also a good resource. I mean, obviously, practically going home, it may not be very practical for everyone. But apart from that, if you just get the videos also of the work being done at home, that also gives us a fair idea.
So I think with this, we come to the end of the session and the time is getting over. So I thank once again all the delegates who joined in and Dr. Shambhavi Seth and Dr. Praveen Suman ma'am for a wonderful presentation and discussion. So thank you everyone. We're closing this session now. Thank you so much.
Thank you, sir.